There are 3 different types of hemophilia. Got it? No droppies. Sure. Oh, yeah, just a little.
Okay, that's right.
Let's go, girls.
And Enrique.
Poor Enrique.
Maybe Enrique.
All right, so who does hemophilia affect?
Men.
Mostly men. Sorry, guys. Just the way it is.
Hey.
Women are the carriers, though, so congratulations. If your son has it, it's your fault.
What? Sorry, Enrique.
Yeah.
That was cut off on mine. I'm recording, it's just different order.
It was a weird printage.
Oh, it's just different order.
Right. Why do you think it affects mostly children?
Does it just develop when they're children?
Just because they have immature immunity, so
Not quite.
they're still trying to build it.
It's going to make sense in a minute. Okay. X-linked recessive genetic disorder, which is a rare bleeding disorder in which the blood does not do what? It does not clot. That is correct. Hemophilia A, which is the classic hemophilia, the one that you're going to see pretty much all the time, affects up to 90% of all the individuals that have hemophilia. It is obviously the most common form. Hemophilia B, which is also called Christmas disease, but has nothing to do with the fact that it's just the person who discovered it, last name was Christmas. Yes, ma'am?
Hemophilia A is most common?
You are correct.
Okay, sorry.
Stephen Christmas was the first patient diagnosed with hemophilia A. It doesn't, you don't need to know that. It's just, that's why it's called, also called the Christmas disease.
What a Christmas present.
Merry Christmas. Hemophilia. So where do we usually see the effects of hemophilia? Where's the first sign that we see?
When they break a bone. Fatigue eye? Bruising? No? When they break a limb?
When they fall down?
Headaches.
Uncontrolled bleeding?
Nope.
Oh.
Joint pain. Because it bleeds into the joints. So if you have a kid that's not fully developed, their ligament, their tendons, all their joints haven't completely developed, they have more space in their joints, right?
So this is why it's most common in children? Okay.
It's easier. It's, the blood is going to take the easiest path flow. So it's going to go to the joints. So you're going to see horribly inflamed joints. Typically the knee joint.
Do
Okay?
you feel heat or anything when you touch it?
I have pictures, you'll see. It is extremely painful. But the most dangerous site for hemophilia, where do you think that is? In the head. You have a patient that's been diagnosed with hemophilia and all of a sudden they are unresponsive, you have minutes to react.
They're bleeding out.
They are bleeding out from their brain. They need to go to surgery. Bless you. They need to go to surgery, and they need to have a scan done immediately to find out what part of the brain we're going to. It is typical and normal for individuals to have a slight amount of blood in their urine on just a daily basis. It's completely normal. They're very susceptible to nosebleeds, so during the winter is not their friend. You know, that's nice dry air outside, and all of a sudden they're constantly having nosebleeds. Much more difficult to stop. And then they constantly have tightness in the joints. All right, what's your patient gonna look like?
Achy,
Achy?
bleeding, nosebleeds.
Nosebleeds?
Joint warmth and pain.
Throwing up coffee ground emesis?
Pain. Oh, that's achy.
Why would they have good dental hygiene?
Or is it important too?
It's important to have good dental hygiene.
I was like, oh, okay.
The
Yes.
bleeding of your gums and stuff.
Yeah, your gums start to recede, they'll constantly just bleed from their gums.
They need be cautious of their activities?
No, just what do they look like?
Oh, they're
And this is
pain.
assessment. This is the manifestations of the patient.
They'll have bruises in different stages.
Mm-hmm.
swollen joint.
So if you have a child coming to the ER that has bruises in different stages, and they're achy,
DC.
and they've had nosebleeds, I can tell you we don't go to hemophilia. Where do we go to?
Abuse.
We're going to abuse. That's where we typically walk to. For the most part, it completely makes sense. They're not going to have broken bones. Okay, their bones, their calcium is not affected by this. All right. So the treatment. What are the treatment for these patients?
Clotting factors.
I'm sorry?
Clotting factors.
You need some clotting factors.
Was that what
Specifically DTAVP, okay? Desmopressin is the clotting factor of choice given to patients with hemophilia B.
You said DDAVP?
Yeah, it's right here.
With A or B?
DDAVP for A. And for B.
It's
For
the
both,
best.
okay.
Mhm. It is the treatment that the doctor is going to go to first. What are some measures you can take just for physical support for the patient?
Pain management. or-
Okay. What kind of pain management should they be on?
Not a blood thinner.
Not a blood thinner. What else not? So no aspirin, what else?
No nonsense.
No NSAIDs, absolutely. Nothing where it's going to assist in the monstrous amount of bleeding they can already be susceptible to.
So are these people going to need a rest constantly throughout the, or do you like?
Not necessarily, they're not fatigued.
Okay.
They have enough iron, they have enough hemoglobin, it's just they're constantly bleeding.
Is it the pain that they need rest for?
They don't necessarily need rest.
Okay.
They might need some immobilization, depending on what joints are being affected.
Okay.
But if their joints aren't affected, they don't really need any rest.
They shouldn't be playing like football or anything.
I wouldn't recommend it.
No, that'd be
I babysat.
I mean, they can, it's up to them. But- What's that?
When I babysat for my friend's kid who has hemophilia, he comes up to me and he's like, I have hemophilia, you know what that means? It's like, no, what does it mean? He goes, I can punch you, but you can't punch me.
Oh,
And
that's
it's
exciting.
just right in the body.
Oh, that's exciting.
Buddy, cool.
And boxing.
All right, von Willebrand's disease. This is the least common of all three. There is a very specific lab when it comes to this disease. It's simply called bleeding time. That is what the lab's called,
Bleeding time?
bleeding time. And the only time you'll see this lab done is if the patient has hemophilia. We don't do this lab for anything else.
What does
And-
that lab do?
It actually shows the bleeding time. What is the normal bleeding time, do you know?
No.
Anybody know a normal bleeding time?
Like 30 seconds before it starts to clot.
60 to 90 seconds is a normal bleeding time. With von Willebrand's disease, it can be well over 500 seconds before the patient starts to clot.
So you just sit
If
there
at
and
all.
observe it?
Yeah.
You just observe them bleeding?
Oh, no, it's a test. No, it's actually a lab test.
Oh.
Yeah. No one's going to stand there and watch. Besides, you're not going to be able to actually see if it's clotting
Yeah.
by the naked eye.
It would be like just drawing blood and testing it that way.
Mhm.
So there's
Yeah.
60
Oh,
to 90 seconds before the class.
Yeah, a normal clotting factor takes 60 to 90 seconds. Some people are a little sooner, some people are a little less. But for the most part in that area.
They can test for like, cause I've released like ones that are like von Willebrand's like tests,
Mm-hmm.
like so they can test for like a gene or something.
Yes, yeah.
But you know,
Okay, yeah. They can do genetic testing on it. Some individuals, if they have it, they're kind of like, what's the point of genetic testing? But some parents might want to have it done in case they have other siblings that they just want to watch.
We get a lot from peds if, you know, they do the 3 clotting factors,
Mhm.
and that's one of them,
Yep.
whatever.
Not the funnest thing to have, but how do people do? Right. Understanding labs. What does your PTT measure? I heard someone read it.
Intrinsic.
Intrinsic arm of
The
coagulation.
Yes.
Yeah. What drug does PTT go along with?
Heparin.
So if your patient's on heparin, is that arm factor going to be shorter or longer? Longer. Because you want the clotting agent to not clot as fast. So you're going to have a longer arm. What happens when you have a patient that gets heparin-induced thrombocytopenia? All of a sudden you go from a nice long arm, it shortens up because the heparin is now doing the reverse effect of what it's supposed to be doing. When someone has hemophilia, their PTT will be naturally longer because they're not clotting as well. What medication goes along with the PT-INR? Warfarin. Coumadin, whatever. Same thing. This measures what?
The extrinsic.
The extrinsic arm. So again, you're on the patient's on this measurement, on Coumadin. You want their extrinsic arm is going to be longer. This is what we want. These are what the tests are actually measuring. So bleeding precautions.
Randy.
Hmm?
Said Randy.
Randy.
So you only want to use an electrical razor so you don't cut yourself.
Right? It's not someone that should go into the barber shop and having straight edge done, even those they're
Beautiful.
nice, smooth shaves, but
Absolutely
yes.
beautiful.
No aspirin.
No aspirin. You can easily put no NSAIDs next to that.
If you're gonna stick them, no big one.
This is someone we're going to avoid IM needles. Sub-Q needles, I'll be fine. IVs, that's fine. But if we have to put an IV in this patient, we're getting a nurse that's got a lot of IV experience. We want to poke this person one time. We don't want to be sticking them multiple times with IVs.
14 in the EJ. Let's go.
Yeah, let's go. Let's do it.
Protect them from injury.
Mm-hmm. Obviously, you cannot force somebody to protect themselves from injury. If they want to go out and play lacrosse, play football, play soccer, it's completely up to them. You can't force someone to do it.
And
Or not to do it,
stress-
excuse me. What's that?
Oh, I was gonna say, and stress the dental hygiene on the dentist.
Yep. Good to the dentist.
Mm.
What are you going to observe for?
Bleeding in your gums, bruising.
Where's a couple places you're going to observe for almost right away? Bleeding in the gums was one. What was the other one? Urine?
Poop.
No. Not yet. That's not going to happen right away.
The vomit,
No.
I know.
Nosebleeds.
Oh, okay.
Yeah, nosebleeds are going to be one of the first things you see. So, blood in the urine, nosebleeds, gum bleeding, and bruising. If the patient has tarry stools, by this point they should be notifying their physician because now it's gone a little too far. Because the tarry stools the blood has to be processed through the entire GI tract and they actually can take a couple days. So they've been bleeding now professionally for a couple days. Right. This is a typical hemophilia need. You guys see that okay? What do you think the first thing the nurse should do if you see a patient like this? Elevating's not going to do anything.
Well, do they know they have hemophilia at this point or no? Because the first thing you want to do is check for hemophilia.
And just in standard. You haven't drawn any labs. You just want to do an intervention for the patient.
Oh, I'll give them some ibuprofen.
No.
Ice.
No.
I don't know.
You want them putting weight on this thing?
No.
What do you want to do?
Non-labor.
You want to get their leg elevated. I'm sorry, not elevated. You want to get their leg off the floor and you want to mobilize it. Put the mobilizer on. This is an individual that should not have his knee bent right now. It's a lot of pain. You can give them all the pain medication and ice in the world. What needs to be done?
Stop.
You can't not gonna be able to do that.
Drain it.
Yep, needs to be drained. That doctor needs to come in and drain this real quick.
And just doing that will relieve a lot of pain.
It will take the pain away. You'll be like sore, like a regular sore muscle, but the pain will be gone. All right, why don't you guys take 15 minutes and go get some soup, go get some caffeine. Come on back.
Do I look sleepy to you?
What?
What are you implying?
Do I look sleepy?
Y'all look tired.
Wait.
Oh.
There's a whole bunch of like soups and stews and chilies down.
Smells like something that my dad says once a day.
I don't drink beer.
I don't either, but the commercial comes on TV, and every time I see it, I crack
The
up.
Merlin commercial is hilarious. Turn me into beer, and he's about to do it. I'm like,
I love when they make you laugh. That's the kind of commercial I like. It makes me laugh. Oh yeah, yeah. Make my kids laugh.
okay. Has anybody heard of DIC?
Yes.
Dying.
From Dave.
From what? From Dave?
Death is coming.
This is the worst thing I've ever seen anybody die from. And for the entire time I've been doing this, I've only had 3 patients have it, and they all died from it. So what is going on when I say DIC? It is a bleeding thrombic disorder, right? But what is happening is it's very rapid. It has a very, very rapid onset. This isn't a chronic disease. Someone doesn't live with it. They typically get it for a reason. Sometimes they get it because of chemotherapy from leukemia or any kind of blood cancer. It is brought on, the clotting factor is activated, so the body declots at a rapid pace to the point where the pancreas has no shot of reversing it. I've had patients die within minutes. The longest patient I had, she was good for about 4 hours, and she was swinging back and forth the whole time. She was bleeding really bad, and all of a sudden everything would clot real fast, and then she was bleeding really bad. But what happens when the body is trying to swing the pendulum back, it's doing it at a very rapid pace. So now you have the prospect that your patient's about to have a stroke. Because you're way over here, everything's bleeding out. Your internal organs, your pancreas and everything tries to throw as much clotting factor as it possibly can. So all of a sudden your blood gets real sluggish, like honey. And now your patient just threw a clot in their brain, they had a stroke and it's died.
Can't this happen after pregnancy?
I have not heard of it, but anybody could get it because with HELP syndrome, which is a very severe form of preeclampsia, your liver, pancreas, and kidneys are affected. They'll start shutting down. So, which guess what? All those directly affect your bloodstream, right? So, absolutely. Let me ask Christine Haggerty and get back to you. Because if anybody's going to know, it's going to be her.
She's sick. Stay away from her for a minute.
Oh, I know, right? And her cubicle's right next to me. I'm like, woman, I'm going to go get you a mask. I told her, I said, you want me to teach your class today so you can go home? Oh. All right, anyways. Any questions? That's DIC. Very, very bad. Yes, ma'am.
Are there like warning signs, or is it like while all of this is happening, it's just like they're normal?
Boom.
Okay, so
It is there's virtually no warning signs until the patient's bleeding out from like every orifice, and you're like, oh, okay, great.
They look like crying Jesus. It's weird.
Their eyes, their nose, their gums will just start pouring out,
like
their ears.
Oh.
That's weird.
It's something you'll never forget once you see it.
Yeah, the picture.
Have you
Alright.
seen it,
Crying
Trish?
blood. That's what it looks like. Yeah.
You've seen it?
It's awful.
It's disgusting.
All right, neutropenia. Tell me what you know about neutropenia.
It's not enough.
Neutrophils
What?
below normal.
It's not enough.
Not enough what?
Neutrophils.
Okay. Why does the patient get neutropenia? All right, what kind of diseases would they have?
Cancer.
Cancer. More or less cancer treatment patients. Because the chemo and radiation are killing everything, right? Even the good stuff. So at what point would somebody be classified for a neutrophil patient? A neutropenia patient?
Is it a certain number you're looking for?
Third number for WBCs. Remember? This is WBCs.
Below 30?
No, it's
Wait, stop.
4.7.
What is a normal white blood cell count first?
4.7 to
11. Just say 11. It's fine.
Okay, 11.
It's like 11.2. I don't care.
Okay.
Okay. So at what point for those WBCs would the patient be considered a neutropenic patient?
I thought it was 3. Higher?
No.
2.
Okay. Very often you'll see 0. You'll see a non-existent white blood cell counts. Okay. So if you have a patient that's a neutropenic patient, I know we briefly talked about this at another time, how do you determine if there's an infection process happening? Because WBCs aren't going to go anywhere.
Oh, you'd look at
Temperature.
Temperature,
the blood test for leukocytes and
possibly. We'll get there. 1 second.
the CR.
Just
yeah,
a
CRP.
normal nursing intervention for neutropenic patients are Q4 vital signs. And this is strict. I don't care if you're waking the patient up at 2, 3 in the morning. If they're in the hospital, they're going to have to be explained. You don't have a white blood cell count. You're under reverse isolation. At this point, you are protecting the patient from everybody outside that room. Because the only thing that is going to stem that they have an infection process going on is a low-grade fever. Once they have a full-blown elevated 102, 103 count, you're in trouble. So once the patient's body system starts to activate again, what are you going to see starting to develop first when it comes to the WBCs? Neutrophils. You guys are overthinking this. So when you have a patient under neutropenic precaution, done with chemo, we're good, the WBCs, everything's going to start waking up. You're going to see a shift to the left, which means the neutrophil count is going to be released. But what is a neutrophil when it comes to WBCs? No baby cell. So why is the pancreas and liver releasing baby cells in WBCs?
They don't have enough mature ones.
Yeah, they don't have enough mature ones yet, but they're trying to help. So you're going to see a massive shift of neutrophil count's going to go up, and then the WBCs are slowly going to go up, and as the WBCs go back up to normal, neutrophil count's going to go back down. Okay, completely normal, completely normal. It's called a shift to the left, though. Okay, that's just what it's called. It's an anatomy thing. So for a patient that is under neutrophil precautions, they're starting to get a temperature, right? They're on their antibiotics. They cannot take acetaminophen. They can't take NSAIDs, all right? If you're on chemotherapy, you can't take those 2 things. What do you think the drug of choice is for individuals with a high temperature that are under neutrophil precautions? What? Morphine. 10 milligrams IV push morphine.
And that'll also bring down the temperature as well?
It will bring down the temperature. That's why we're giving it. Let's go right into leukemia. There are 4 different types of leukemia. You can read the 4 different types if you'd like to. What is the lab test we check and monitor for leukemia? What's the big one?
Innate white blood cells?
White blood cell count. So we've already covered a normal, regular white blood cell count, right? A normal high is about 11.2. So if you have just a normal infection, UTI, pneumonia or something, you might jump up to 16, 17, 18. Nothing crazy. Nothing's going to kill you. What is a normal white blood cell count for leukemia patients? It's very high.
13.
Where?
30.
Where?
45.
Wait, go.
16,000.
Go. Up. 100?
136.
1 over 150.
Oh my gosh.
My little brother had a physical done because he just said he wasn't feeling good. and he said his pee looked a little bit weird. And I was like, well, you probably have a urinary tract infection. I said, go to the doctor. And he called me about the next day, went to the doctor, and he goes, so I'm heading to Freighter in an ambulance. I said, well, that's weird. Why? He goes, well, the doctor said my white blood cell count was 151,000. I went, well, did they tell you what's going on? He goes, well, they said I have leukemia. I said, you have leukemia. He goes, how do you know? I said, because your blood count's 151,000. So he was very rapidly started on chemo the next day. PICC line, all that fun stuff. So we will instantly know. What happens also is the increase of absolute neutrophil count is something we'll see follow the WBCs.
The absence of neutrophil count?
Increase. So once we have all these tests done and we have confirmed the patient has leukemia, we only need those 2 tests to confirm they have leukemia, by the way. What do you need to be explaining to your patient?
What's going on?
Obviously, what's going on?
Stay away from sick people.
I'm sorry?
Stay away from sick people.
Well, they're going to be in the hospital for a while. They're not instantly going to put on reverse isolation. We're going to watch their WBCs because we have a long way to cut those WBCs down before they're susceptible to infection.
Did you talk to them about radiation treatment?
Yep, they could have full body radiation treatment. That happens. What is the big treatment of choice, though? It's a blood cancer, so. Nope.
Dialysis.
Nope.
Marrow.
Nope. Marrow's after they kicked it. What's the normal cancer treatment that we always talk about? Chemo. Chemo's normal leukemia treatment. When it comes to bone marrow, when it comes to immunosuppressants, that is later on once they've kicked it. Once their white blood cell count is at a 0 and there's no evidence that the leukemia is still there, then we do the bone marrow transplant. Then we do the immunosuppressants. Okay? So, symptoms of leukemia. We've already talked about the WBC count and the neutrophil count. Why would the patient be susceptible to a low hemoglobin? Your blood supply, your blood volume only has so much room, right?
So
But your body's kicking out how many hundreds of thousands WBC extra white blood cell counts? So can it fit any red blood cell count? No, it's really that easy. Volume. Their H&H are going to be lower because their pancreas cannot have any room to function anywhere else. So if the pancreas cannot function correctly, they are also under risk for bleeding. Because if you don't have enough RBCs, well, where does your clotting agents like to hang out? In the RBCs. Can't have one without the other. So when this patient goes home, what do they need to watch for? What are things that they need to be calling their doctor about if they start to notice it?
Bleeding.
Bleeding? What?
Bruising.
Bruising? Correct?
would a fever be a problem?
Oh, absolutely. That's the big one. We're going to teach them how to take their own temperature. That's the big one. Onset of headache, that's brand new. So if they have a risk for anemia, what does your anemia patient look like? Weak, very good. Temperature, maybe they're not hungry or short of breath.
Mm-hmm.
What's your anemia patient look like? Heart rate high or low?
Hi.
High. Blood pressure high or low?
Low.
Typically low. Very good. Would somebody read, please?
You are caring for a 65-year-old male patient diagnosed with AML, who has undergone his first chemo regimen in the hospital. His platelet count is 60,000 on the day of discharge. You therefore teach your patient which of the following as you prepare him for discharge home. Only use an electric shaver. You should
A.
A.
directly
Everything else causes bleeding.
A is the correct answer. Does it really matter what foods they eat?
No.
No, because they should be eating more fruits and vegetables and fiber, which would be harder for the digestive system, but it's not gonna hurt their GI tract. Temperature rectally?
I mean, if they're into it,
Please, no. I don't care what they're into.
they're
don't do
more
it.
expensive to get a rectal.
Like now you can get the ones where you just set on the forehead. It's great. You may resume all activities and contact sports when you feel up for it. I hope not. Again, you cannot. If they want to go out and play rugby, they can. I mean, you can't say no, but I would highly discourage it at this point in time. You know, go out and play golf or something. All right, any questions there? All right. Lymphomas. What do you know about lymphoma?
There's a non-Hodgkin and there's a Hodgkin.
There's
Absolutely.
Anthony Rizzo.
I'm sorry?
There's Anthony Rizzo. He had
The hockey player?
Anthony Rizzo is a baseball player.
There's an Anthony. Oh, stop it. There's an Anthony Rizzo that's a hockey player. That's why I was like, what? He had leukemia?
He's the one who, he went to the high school where the shooting was. And it's like a whole big thing because,
He went to Florida? Like recently? Oh.
no, that's where he grew up and went to
Oh.
school there.
Oh, he was at the school?
That's where he went to high school, yeah.
Oh
Yeah.
no.
It's a huge thing. Anyways,
That's sad.
It is sad.
All right, so the different nodes. Where do the nodes typically show up in both Hodgkin's and non-Hodgkin's? And listen, when it comes to Hodgkin's versus non-Hodgkin's, that's just the classification. If you know the difference, congratulations. I don't care if you do.
Your neck.
Why your neck?
That's why we have a lot of lymph nodes.
Well, you have lymph nodes everywhere. But why the neck? Why is that the prominent
There's
one?
not as much fat and stuff.
You can
It's
see it, you
there.
can feel it. It's that simple. The neck and underneath the armpit, the axillary. Those are things you can see, you can feel it. The nodes are real close to the surface because there's not a lot of fat there, so you can see it, okay? You have lymph nodes everywhere, but you're not gonna palpate your groin lymph nodes or your liver lymph nodes or your pancreas lymph nodes. I had one of you guys a couple semesters, oh, not one of you guys, but one of the a student in a cohort a couple of semesters ahead of you that said something in her case study about palpating the liver lymph nodes. I was like, well, that's impressive. I've never done that. How did you do that?
I checked his cervix. I'm gonna check his cervix and Gatsby was like,
I
I
have read some very funny health assessment papers. Well, like you totally know what the student's trying to say, but it's completely the wrong
that was my
terminology.
first checkup. I was very nervous.
Yeah. So
I'm sure whoever was doing it probably peed themselves.
I could guarantee though too, after like you sit down with the student, especially health assessment, you explain what I think you meant and what you actually wrote, and they're like, they've never made that mistake. They'll never make that mistake again. It's funny. I don't mark students off for that kind of stuff. I just have them redo it. And
She's like, are you sure he has cervix?
I'm like, is this what you meant to say?
There was an episode of SpongeBob where Mr. Krabs went crazy over that noise, and I'm about to be Mr. Krabs.
The boots. Am I making a noise? I'm not even paying attention.
I'm probably wearing black boots just like yours.
I was not even paying attention.
All right, potential complications. See if I can get you guys back. No, I'm talking about SpongeBob. All right, potential complications from disease progression or cancer treatment. Pleural effusion. What is a pleural effusion?
Fluid.
Fluid where?
Around.
Around the lungs. Drug-induced pancytopenia. This is when we make the pancreas very upset with the world. And it's from the chemotherapy. Being toxic from chemo, skin problems at radiation sites, severe nausea and vomiting. I mean severe. This is a person that the smell of something's going to make them throw up. That they won't leave their bedroom because it's so bad. Impaired liver function, sterility. So if you look at all these, what kind of nursing diagnoses would you come up with?
Risk for isolation. Like,
Absolutely.
Risk for some type of fluid imbalance,
Body.
Possibly. Why? Prove it.
the vomiting.
Vomiting. So what other nursing intervention would go, or nursing diagnosis would go along with that?
Risk for skin integrity.
Very good. Risk for skin integrity. Why?
Fluid volume loss.
Radiation site. They're not eating. Their electrolytes are off. Their fluids are off. They're probably laying around. They're depressed. prime patient to start breaking their skin. What else you got?
Could they have ineffective coping?
Probably, possibly. That would be a case by case base. Some individuals deal with it very well, some don't. It's totally fine. What about risk for infection? You are killing their liver, pancreas, and anything else that may have helped fight an infection with all the chemotherapy.
Would knowledge deficit be one?
Very well possible. But how do you fix knowledge deficit? Yeah, that's on the nurse. Knowledge deficit is being put more and more on the nurse. That's the nurse's fault. The patient doesn't know. Which isn't not always the case. Multiple myeloma. What is multiple myeloma?
Bone
Cancer?
Bone cancer. We'll start with that. Very good. What electrolyte goes crazy high with multiple myeloma? Calcium. Why?
bones releasing.
Because the bone's breaking down, it's releasing the calcium.
My boyfriend's uncle has this.
Oh.
Does it increase calcium?
Yes, because the bone's breaking down, so it's just releasing the calcium. How do you prevent complications from the hyperkalemia?
Hydration, you drown it
That's
out.
it. That is it.
Okay.
Water. They need to severely increase their water intake to keep the calcium flowing out of their body for the kidneys to get rid of it.
Is it hyperkalemia?
Hyperkalemia, yep. Calcemia.
Calcemia.
Calcium. All right. Sorry, Annie.
Hypercalcemia.
Because if you
If they're nausea
Diluting
vomiting to the point where they can't take anything in, and their kidneys are working fine, this is someone that's going to be on high volume of IV fluids every hour. Okay. Because what are your signs, symptoms of hyperkalemia?
Trousseau's and Schwartz.
Okay.
HBs.
Mm-hmm.
Muscle weakness.
Muscle weakness.
Nausea vomiting.
Nausea vomiting. What's the big one? What has to do with neuro?
Oh, lethargy. Seizure.
Seizure. There it is. They are high risk for seizure. All right. Clinical manifestations of multiple myeloma. What is your objective ones?
Spinal cord injury.
Spinal cord injury. Kidney stones.
Renal failure.
Again, why do you have kidney stones? Why do people typically get kidney stones?
too much calcium.
Too much calcium. Okay. Acute renal failure. This is why you have to watch this patient. If they're in acute renal failure, you can dump fluids out of them into them all you want. What may an intervention have to be then?
Dialysis?
Mm-hmm.
Okay.
They might have to go on short-term dialysis because if it is truly an acute renal failure, an acute means we can fix it still, but we just might have to help them out for a little bit. Yes, ma'am.
Why would they have spinal cord injury? Is that because the bone, the spinal cord bone?
Yeah, your vertebrae is breaking down just like any other bone. They may or might not have a bleeding disorder just because of everything going on with the electrolytes. Just like any other cancer patient, they're at risk for infection. So what's your nursing management? What are you going to do?
Pain.
Absolutely pain. What else? Fluids. All right, a laminectomy is nothing, unless one of you become a surgeon, you're not going to do laminectomy, but we might go in there and we can actually put new vertebrae in. Especially, this is for someone that has had the cancer and is in remission, or we've cured it, and then we'll go in and take the old stuff out and put the new stuff in. Okay? Works very nicely. Radiation therapy? Oh,
There's no paralysis?
Unless they mess
not if
up.
you do it right.
Yeah.
Okay, we're good there? All right, somebody read, please.
A 72-year-old male patient is hospitalized with multiple myeloma. A priority nursing diagnosis is risk for infection related to immunosuppression secondary to chemotherapy treatment.
Okay.
Which of the,
Oh, sorry, go on.
Which of the following is most appropriate for this patient?
What's that?
Washing your hands. A. Oh, never mind. Didn't
Yeah.
write it all the way.
D.
D is the correct answer. Is A correct answer?
It's not the most correct.
It is not the most correct. B? Good answer, right?
It's not the most.
Yeah, what are
Exactly.
she's gonna
Just help your immune system. Help you. C. I don't think anybody should be doing that personally either. There's E. All right. Questions, comments, concerns there. This also would work for any child, because children love not to wash their hands after they go to the bathroom. I don't know what that's about. All right, let's talk about the spleen and we'll take a break. All right, disorders of the spleen. What is the number one sign that there's a disorder of the spleen? It is enlarged. You instantly know something's wrong. So if you have an enlarged spleen, what do you want to do now?
Tests.
Be careful. No.
Text? What?
Tests.
Test. Oh, what test? I'm like, who are you going to text? The doctor. Patient's spleen is enlarged.
Well, you don't want to do contact sports or be.
Absolutely not. No contact sports.
Don't get mono.
Don't get mono. Does she get any kind of infection?
No.
So what should the patient be doing?
Staying in their house, not talking to anybody.
Washing their hands. Stay away from highly populated area. Especially if they have a splenectomy. Yes, we can remove a spleen. So if we remove a spleen, what do they really have to watch out for now?
Everybody.
Infections. This is an individual that we are going to highly suggest to get vaccines. Not all of them. It is a little ridiculous how many vaccines are out there. Like, oh my God. I think with our 6-month-old, we were looking at vaccines, and there's like 48 different vaccines she could get between now and 3 years old. Some of them I don't even know what they are. I personally think the kids should just get the chicken pox. I got the chicken pox. I died. I don't know. But I think it's a little bit ridiculous. But the vaccines that we're talking about for these patients are just like the flu vaccine, the pneumonia vaccine, things that are just going to help them out. I would suggest this to an individual that go and get like the hepatitis series. They don't have a spleen anymore. They're not going to take, their body's not going to take it very well. But they could get the vaccine possibly before we go take the pancreas out. I've had patients do that. Any questions on spleens? All right, go take 15.
$4,000.
We just got one at work and it's broken.
They get that from me in a month, so.
Our ICU has an
True
espresso
story.
maker.
They're hard to maintain.
Okay.
I'll clean the bastard.
Yeah, but who's going to clean after you graduate?
Well, then I don't care anymore. I don't care.
Exactly.
So,
I can respect that answer.
well, you know, at least I'm
All right. What do you know about blood products?
You
Type screen.
4 hours. You have to have a certain
They take a lot of steps.
tubing.
They take
Yeah, you have to make sure that they're. for
Even
your
though we
patient,
donate them, they
everything.
charge the patient. Sorry, what? Go
We're
ahead.
giving you a headache, aren't we?
No.
I have a problem with it. Go
They
ahead.
don't charge the patient for the blood. You know what they do? They
The
charge the patient for everything
administration.
else.
You
The
need consent.
The pump, the
You
pole.
need consent in order to give somebody
Yep.
blood.
Do you consent? That's
You
important.
need to make sure
Type in screen, very important.
with somebody else that it's the right patient, the right product, everything.
What's the
right.
very first thing you should do once you have an order from the doctor to give 2 units of whatever?
Make sure that you
Make
have
sure
an
blood
ID
type.
on the patient.
Consent.
Ask the patient first.
Consent.
You need to consent first. Don't bother doing anything else. It is a waste of time and a waste of money and a waste of everything. If you do all that stuff and then you walk into the patient's room and the patient's like, I'm not taking blood, I'm a Jehovah's Witness. You have just wasted so much time and resources. Always go in and talk to the patient first. Now that you have the patient's consent, They're like, yeah, knock it out. Do whatever you need to do. Now what do you, now what
Now
do
you
you do?
need to.
Now you make sure they have a decent IV, but also get the typing process going. Get lab up there to draw what you need, because what they do takes about 30-35 minutes. Get a good typing screen going. Get that going. What should you be doing in that meantime? Got a good IV in, it's running great.
Vitals.
What, vitals? Okay. Yep, your baseline vitals. Who can take
Preparing the
those?
patient.
Sure,
Nobody
but
can. Anybody can take the baselines.
anybody can take the baseline vitals.
But wasn't it, if it's always something important like that, you kind of want to do it yourself?
These are just baseline vitals.
Okay.
Anybody can do vitals. Actually, anybody can do any of the vitals. The nurse just has to be present. You got other stuff to do. Have someone else do it. Okay?
Band the patient.
What's that?
Band the patient.
If the hospital does blood bands, make sure you get a blood band on the patient.
Not too common anymore.
It is not common anymore at all. Hospitals are getting away from actual blood bands. They're just using the regular patient band.
Oh, they got ours. We just got them too, that's the funny part.
You just got them and I got rid of them?
No, we still have them, but we just got them, which I think is funny.
Then I would venture to say you're probably going to get rid of them soon. It's one less thing for everybody to have to worry about.
Yeah, this
It's
takes
just,
longer than normal.
They don't
What
care.
is a normal platelet count? You guys remember?
100.
50 to 40.
Yeah. I can't
And what is
say
a
right.
critical platelet count?
Less than 2,000. 20,000.
30 or 20?
30.
30,000. There you go. 30,000. So I will tell you right now, unless there is something going on with that patient, they have to have surgery, they have to have some kind of tap done. Unless the patient is under that 30,000, it is very atypical to give them platelets. So if you have a patient that has over 30,000 platelets, but they're still really low, and the physician's ordering platelets for like no reason whatsoever, the patient's completely stable, they're in bed, they're chilling, they're great. You need to just ask that doctor. He needs to give a reason. Anybody know why?
Reasons for what? Sorry.
To give platelets if they're not under 30,000. If they're under 30,000, it's automatic, they're emergent, they need platelets. Go ahead.
Won't insurance not cover it?
Insurance won't cover it. Now, if the patient needs to have a thoracentesis done because they're filling up, the physician will put that, insurance will cover it. Unfortunately, a lot of what we do is wrapped around what insurance will pay for and what they won't pay for. And I know a lot of people hate that, but just think if that was you in the bed and you were going to have this massive hospital bill, wouldn't you want everybody doing everything they could to knock it down?
Mm-hmm.
So just kind of think about that. And listen, I know doctors that will be like, I don't know why I have to write it. Just put it in the reason box. It'll take you 5 seconds of your life. Just do it, okay? All right, let's talk about the actual reactions. There's a hemolytic reaction, allergic, febrile, bacteria, and circulator overload. The most common is febrile. The most severe is hemolytic. Why do we just use 0.9 normal saline with blood? Why is that the only thing that's compatible with blood?
Could other things cause reaction?
Say it again. I heard homeostasis and something else.
Could other things cause a bad reaction?
Because other things are too hypotonic. And you don't want to give something like D5. You don't want to give something like lactated rennet because those all have calcium in them. And what does calcium like to do with blood?
Fine.
It binds, it coagulates it. We don't want that. Okay, very good. So let's talk about the most dangerous reaction. Also one of the most uncommon. But if you have any type of reaction whatsoever, any type, just a mild fever, itching, nausea, anything, what's the first thing you should do?
Stop it.
Stop the blood. Do not throw the blood away. Just stop it and get the normal saline part flowing in. What is the second thing you should do?
Vitals?
Nope.
Get the doctor.
Get the doctor involved. You need to call the doctor and let them know what the signs and symptoms are. Yes?
Is this considered a rapid response, or is this just considered a phone call?
Depends what the patient looks like. Patient's talking to you, but they're like, I'm itching all over. No, absolutely not. Patient all of a sudden goes unresponsive and can't breathe. Please, by all means, call code. Okay? It completely depends. If it's a hemolytic reaction, this is an emergency. This is a code situation. Very often, it's an anaphylactic response. So how do you treat an anaphylactic response? Epi? What else?
Benadryl.
What else? What else? There you go. Keep going.
Well, this is corticosteroids and basic.
There you go. Imagine that. This again is the most severe. It's the least common. So here is all your reactions for it. Usually, they all usually occur in the first 15 minutes. Okay, all of them. Burning sensation as the vein is a very typical red flag when it comes to hemolytic because the bodies are already not reacting well to it. Flushing of the face, the body's going into fight response. Apprehension. If you ever have somebody, I don't care where you're at, I don't care if you're at the mall, at the movie theater, if you have someone just say, I don't know, I just don't feel right, for them, gotta get help. When they say, I just feel like I'm gonna die. They have that sense of doom. I've had 2 patients in 17 years tell me I just feel like I'm gonna die, and they coded within the hour and died. No rhyme or reason, they just did. They had no heart issues, they just coded, okay? Lumbar pain. Why are you having lumbar pain? It has nothing to do with your vertebrae, by the way.
I get it from lack of fluid.
Is that your kidneys?
Kidneys! And that's why your kidneys are all set. It is attacking your kidneys, so you're going to get lumbar pain. You're going to get a headache, same reason. And then chest pain. That is hemolytic reactions, okay? So let's go over to allergic reactions. A little more common. They essentially are having an allergic reaction to the blood, which is possible. So what is your patient going to look like?
Flushing.
They're flushed? What else?
Hives.
Mhm.
Hives. Wheezing.
Okay.
Anxiety.
Wheezing. Wheezing is a very common sign symptom of an allergic reaction because the lungs are getting involved and they're spasming because it's an allergic reaction. Why do people get an allergic reaction to blood?
Body's rejecting.
Very specific. Go very specific.
Different factors.
Plasma. They're allergic to the plasma protein. You are not allergic to peanuts. You're allergic to peanut protein. You're not allergic to the item. You're allergic to the protein in the item. Most people that are allergic to peanuts can have peanut oil because peanut oil removes protein. I thought I was going to send my nephew. I know, mind blown, right?
Why they ban Chick-fil-A?
I thought that was exactly where I was going. I was on vacation once with my whole family, and my now 18-year-old nephew was in junior high, and we're just going to run to the Chick-fil-A quick and grab some food, and the only thing he eats is chicken and mac and cheese. So I got him chicken strips and some stuff, and he's eating them. He's halfway through his meal and turns the box over and said this may contain peanut oil. So I just stopped the car and looked at him. I said, well, you look okay. And he is like a severe peanut reaction. Like I've stabbed him with Epi on several occasions. His face will swell up, his esophagus will swell up. And then I looked it up. I did not know that you can, if you take the protein out of it, you get peanut oil. People are allergic to the protein.
I feel bad for Peanut Boy in high school. He came to our school and they stopped serving Chick-fil-A and everyone hated him.
You just call him Peanut Boy?
That's what we called him. I didn't know his name.
Wow, you're such a
You hate him because he
No,
went
I
to
didn't know
Chick-fil-A
him.
before going to
Yeah.
school. It just sounds like someone that planned accordingly, that's all.
Yeah, they stopped serving Chick-fil-A because of him.
Stop serving it.
Why?
Because he's allergic to
peanut.
peanuts.
What
What's
Like,
going
I
on
guess-
when they were serving Chick-fil-A?
I was on Thursdays in
It
Angleton,
was
Texas. You had to pay extra.
Right, how do we get someone to serve Chick-fil-A to us?
But you had to pay for
That's
it.
the-
It was
Yeah.
like more.
I got $5 off.
Like Chick-fil-A.
Dude, I didn't even shut about Chick-fil-A.
I don't think
That
I
was
used
nice.
to.
You're nuts.
All right, manifestation of allergic reaction. What's your patient going to look like?
Rashes.
Rashes.
Flushing. Bronchospasm.
So the wheezing,
Hives.
Sweaty.
itching, sweating,
What is the first one?
Hives.
hives. Yes, ma'am.
Puritis.
Pruritus.
That's a change.
Oh, okay.
What is normal allergic reaction?
Yep, there's a normal rejection patient. Again, what's the first thing you do?
Stop the blood.
Then what do you do?
Call it out.
Saline.
When it comes, what?
What'd she say? Saline. Said saline.
Like you said smile at first. I'm like, you're mean, okay.
Smile as a patient.
You're having a allergic reaction.
I should call a code.
For this, no.
Okay.
The patient will be fine. Very typical. The physician will probably just order some medication to treat the effects and then just want you to do the blood at a slower rate. But some doctors will just stop it altogether. It depends. And it depends how severe it is. If they're itching and have hives, but it's a quarter of this, yeah, they're having a reaction, but if you slowed the blood down and put it over 3 hours, would they be okay? So it's really case by case. So let's go into febrile reaction. This is the most common. This is what you're going to see almost all the time if there is a reaction. So what is your patient going to look like if they're having a febrile reaction to the blood? Chills.
They're gonna have
Rapid
like
heart
a
rate.
fever.
With all three of these, the heart rate's going to go up, the blood pressure's going to go down, okay? So don't make that a contributing factor on the test.
Okay.
All three of them are going to have the same. But this one, febrile, they're going to have fever, right? They're going to be chilled. Should be pretty easy. They're febrile, they have fever. So good. They're having this type of reaction. The first thing you do is
Stop.
what typically happens after you stop the blood, you call the doctor and you tell them this is going on. They will order acetaminophen if it's okay with what's going on with the patient, some IV Benadryl, and they'll tell you to keep going. This is a very, very mild reaction. And if the patient truly needs the blood, they would rather do the Benadryl, the Tylenol, and go on with life. Many doctors nowadays will order 1,000 Tylenol and 500 IV push of Benadryl all the time now, just even before you give the blood. Anybody have any clue why they're doing that?
Because it's so common now.
It's common, and stop bothering me. Or they'll put the order as a PRN for signs, symptoms of febrile reaction for blood. Then you really don't have to call them. It's just a bit easier for everybody. All right, you guys can read. We've gone through all of these. There's different things. All right, bacterial transfusion reaction. Why would someone get a bacterial transfusion reaction?
Bacteria.
In the blood that you're giving.
Contaminated blood.
It's contaminated blood. Yep. The nurse has not done anything wrong. So you're going to see a lot more, it's happening a lot more, that you're going to see filters for the blood coming more and more often. The filters they're coated with silvadine. Silver. What does silver do?
Well, I thought it was for
Antibacterial.
burns, but.
It is.
Yeah,
Oh,
antibacterial.
I heard
It can
it.
be used for a lot of things.
Antibacterial.
Antibacterial. So silver is a natural antibacterial. Silver and honey. You didn't know that, is it?
I know that about honey.
Honey does everything. Honey's amazing. Real honey.
Give us some honey.
Some honey, sugar. All right. Manifestations. High heart rate, low blood pressure. It's very sudden. Fever, chills, signs and symptoms of shock. What are your signs and symptoms of shock?
Like, you don't know. Mint or. I can't say.
This is a physical thing. This is a physical shock.
Oh, okay, so you're not gonna, like, start eating.
Pale skin,
Pale skin,
sweaty, diaphragmatic.
sense of impending doom,
Yeah, that's what I'm trying
chest
to.
pain. It's all physical reaction though. It's all physical reaction.
So shock is how you would tell the difference between bacterial and fecal?
Possibly.
Okay, because they kind of look the same.
Febrile is going to be much more mild.
Okay.
Like a heart rate that's 80 might go to 100. When it comes to bacterial, a heart rate that's 80 is going to go to like 150.
Okay, so
Yeah, it's a much harsher reaction. Any other questions with the bacterial? All right, and then we have overload reaction. What is the most common patient that gets overload reaction? What medical diagnosis do they typically have?
COPD.
CHF.
CHF, there you go. You can very rapidly put them into a CHF crisis if you give blood too fast. This is an individual where you'll be giving 1 unit of blood over the full 4 hours. You'll be giving them Lasix in between. And there's someone that's monitored pretty darn closely. What does the patient look like if they have circulation overload? JVD. What's going on with their blood pressure? Okay, so of all the 5 we talked about, this is the only one that blood pressure goes up. Bounding pulse. They're having trouble breathing because they're in fluid overload, so fluid is backing up into the lungs. We have a guest. Hi.
I'm okay with this, guys.
I want to see the little chicken.
Hi. You want to say hi? Okay.
Oh, of course she wants to say hello. Look at us. Oh my god.
Sure she wants to chew, Trish.
I'm gonna eat it. Oh my god.
It's not an it.
It's a little.
What is that? Look at the piggies. Look at her look. She's like, what in God's name?
What are all of you?
Scary people.
I love the
looking at me.
onesie, first of all.
Because they all cute. Oh my god. Oh, well, she was tired now.
She's
Good
so
to see
big.
everybody.
She's so cute.
She looked at Trish and she started doing
She was like, nope.
That's not true. I know I'm ugly, but you don't gotta show it, baby.
Look, just in case you don't know what happened during the recording, Faye's baby walked in. That's it?
No, it's really good if you know.
Oh my God.
I mean, you can leave if you want.
Yeah, you don't have to stay for the interview.
Oh no, I'm
It's
staying.
not mandatory.
Either you drag me out or you kick me out.
We'll drag you out, all right.
Bring it, lady.
By the nose.
By the nose.
Start telling lies, Pinocchio.
Sorry, my nose will never grow.
He's starting to take it now.
Alright, let me know when you're ready.
I just want to put my
I'm
phone on
born
airplane
ready.
mode and then I'll be ready.
Okay.
Wait a minute.
Because I hate when people call and then it screws up my stuff.
Yes, wait a minute.
Okay.
I mean, this isn't going to go in any particular order because once I put the exam in, everything randomizes. So it's not going to go in order from like the slides, just so you guys know. Okay. Where are you going?
She decided she doesn't want it anymore.
Different method.
Different method, okay. All right, what do you need to do if you suspect any sort of blood reaction?
Stop blood.
Stop the blood.
Then?
Saline
Call the
blood
doctor.
Then?
Benadryl. Your
There you go.
So suspect.
Change my mind. Sorry.
It's fine.
All of them.
Quick question. This exam is starting from heart
This is
failure.
all cardiac and all hemo. So there's 4 different PowerPoints on this, okay? Right, what is the normal hemoglobin and normal hematocrit counts?
For women, it's 12 to 14.
Okay, good.
For men, it's 13 to 14 to 18.
That's fine.
roughly,
Yep.
14 to 16.
Good.
Hematocrit for women is 35 to 45, and
Good.
for men, it's 38 to 50.
Perfect. Guys, get that?
Mm-hmm.
Okay. What does your patient look like if they have anemia? Did I just say ew? Someone just said
Pale.
I said pale. Oh, pale. I'm like, ew, that's not very nice. Oh, yeah. Pale, what else?
Fatigued.
Fatigued, very good. What else?
Low blood pressure.
Low blood pressure and
Increased heart rate.
perfect. And also, occasionally, you can have different types of heart palpitations because of the low iron count, oxygen count that's going through the blood at the time, okay? let's talk about iron deficiency anemia. How do you treat iron deficiency anemia? You guys are so smart. What foods are higher in iron though? Because some people don't. Spinach. What else?
Red meat.
Red meat. What else?
Chicken.
What do chickens lay?
Egg.
Egg.
Okay,
I was gonna say egg.
So protein?
protein. And what kind of grain?
Whole wheat.
Very good. Okay. You guys gotta remember, some patients, they don't want to take a pill. So what can they intake that doesn't taste horrible? Because God bless you all that eat kale, but there's something weird tasting about kale. If you have an individual that's had any type of bone problems, so bone surgery, a break in the bone cancer, what are you going to see a high count of?
Calcium.
Reticulocytes.
Ah, there you go.
What?
Reticulocytes. Because if you have a broken bone, your calcium level is probably not going to go up very much. If you have bone cancer, it will, because the bone is deteriorating. You're going to have a high count of reticulocytes.
How do you
Very
spell that?
good. What's that?
How do you spell that?
RETICULOCYTE.
And reticulocytes are immature red blood cells.
I don't know how to spell that. Okay, that's all.
All right. You have a patient with megaloblastia anemia. They're also on methotrexate for rheumatoid arthritis. What are they going to be low in?
Folic acid.
Very good.
What?
Folic acid.
Folic acid.
What's the medication?
It's called methotrexate, and it's a medication for rheumatoid arthritis.
Is that what that question was up there?
Possibly. I have to relook at it.
Okay, because I remembered saying no this.
What?
Okay,
Folic acid.
Folic acid.
so they should take folic acid.
One of these days, that the medication commercial is going to go on. I'm actually going to have to pay attention for it to see if it actually says anything about a decrease in folic acid. Because it might, but I tune those commercials out. So, all right. What's the main side effect of iron supplements?
Black tar stool.
Good. So if they have it, please don't call the doctor. Everything's fine. What would be a key nursing diagnosis with somebody with aplastic anemia? Remember what the little cells look like?
Boomerangs.
Boomerang. So,
Pain.
not pain. Hmm?
Clots.
Nope.
What are you asking? What's the question?
Oh, what nursing diagnosis?
Infective tissue perfusion.
There you go. Well, I thought you had it for a second there. Because idioplastic anemia, they can't transport correctly. So the patient is a high incidence of, go through your care plans.
Oh, hypoxia.
No,
Ineffective breathing.
no,
Is it clotting?
no.
Isn't it infection?
There you go.
Infection.
Y'all need to be hanging out with Brittany for this test, apparently.
Risk for
What
infection.
kind of? Don't bother. No, I'm joking.
It's risk for infection.
Risk for infection.
Because the cells cannot transport the nutrients.
No, which anemia?
Aplastic.
Oh, aplastic.
An aplastic is not like sickle cell. Sickle cell is the one with the boomerang.
Mm-hmm.
Yeah.
Okay.
I was gonna say.
Is risk for infection?
Yep.
Because they have neutropenia.
Mm-hmm. Right. What would be a nursing diagnosis for someone with peripheral vascular disease?
Risk for injury.
Correct, and why?
Ineffective tissue.
They can't have no feeling.
Yep. See, sensation. Very good. Good job.
Risk for injury.
For peripheral what?
Peripheral vascular disease.
They have neuropathy issues, so they can't feel, so they're at risk for injury.
Do you say vascular or artery?
That's vascular. Covered that. All right, what's a critical platelet count?
Less than 30,000.
So what did I say about that? If the doctor wants to order platelets but there's no reason, what do you have to do?
Ask them for a reason.
You gotta be calling the doctor and be like, can't give it without a reason, okay?
You said less than 35?
30,000. All right, do you guys remember about polycythemia? What a very key
Yes.
sign about polycythemia is what?
Oh crap.
Oh crap's not an answer. Sometimes it is, but not here. What tends to swell up?
Big
Mm-mm.
toe.
The knee.
No, yeah, that's
That's
hemophilia.
Yeah, that's what I was thinking of.
Polycythemia.
Are we talking about the toe?
Nope. Go up a little higher.
Okay,
The ankle,
Go
Oh.
higher.
give me,
the thigh.
Go lower.
The calf.
The calf. The calf gets painful and swelling. Polycythemia.
How do you spell that?
Polycythemia or calf?
Polycythemia.
Okay. Polycythemia.
And calf.
CA.
LF.
You remember those stupid little words where you're just like, how the heck do you spell out? How do you spell it? You're just
Yes.
trying to do it. All right, what is in the key management for sickle cell crisis?
pain,
Very good. How do you know if someone has anemia?
Blood.
blood.
What specifically?
The hemo, I just wrote something about that.
Globin.
Yeah.
There you go.
Okay.
Wait, what was that question?
How do you know if someone has anemia?
How do you know?
Does hemoglobin count?
Anemia or hemophilia?
Anemia. Just regular old, how do you know if someone has anemia? Just standard old boring anemia. All right, hemophilia. When it comes to that big old swollen knee, what do you need to do with the patient?
Immobilize it.
Immobilize the joint first.
And drain.
Okay, what is that word you just said?
Listen, just
Hemophilia.
the first thing, just immobilize the patient. Because you're not going to drain it. That's not your job.
Okay.
You might assist, but you're not going to actually drain it. All right, what is that lab for von Willebrand disease?
Blood count or what?
Bleeding time.
Oh, blood watch. What was,
Don't know what that is.
I made that up. Lab for which one was it now?
Bleeding time. Von Willebrand disease is bleeding time. What is the nursing intervention you do for someone that's neutropenic to monitor for possible infections?
Fever.
How often?
Q4.
Okay.
You have patients with chicken, what do you do?
How do you know if a patient's receiving chemotherapy for leukemia, how do you know it's being affected? How do you know what lab is going to show you that the
White
chemo's
blood cells
working?
come down.
Shift to the left.
White blood cells.
And what is the shift to the left?
Increase in neutrophils.
There you go. That is the count you're going to be looking at.
For leukemia, correct?
Leukemia.
That was white blood cells, right?
Yeah, immature white blood cells. If you have a patient with platelets under 30,000, if they're getting platelets or not, what is something that you need to be checking on the patient?
Temperature.
Nope, it's
They're,
platelets.
Bleeding.
Bleeding from where?
Nose.
What is one of the first places you're going to see bleeding?
In the
Gums.
urine?
Gums. What is the next place?
Urine?
Urine, very close.
The nose.
Oh, the nose.
No.
No?
Stool?
There you go. We check in occult stools.
If they're receiving platelets.
Even if they're not.
Okay.
There are going to be a multitude of reasons that they're in a critical count, but they're not receiving platelets.
You will see bleeding, or you want to test that to see
You
if
want
there
to
is?
test it to make sure that there's no bleeding. Because even a small amount of blood in the stool means there's an active bleed somewhere in the GI tract. You okay?
Mm-hmm.
All right.
Do you wanna, so, if your patient has less than 30,000 platelets, one of the tests you're going to do is you're going to see if their gums are bleeding, or
Mm-hmm.
do like a guaiac.
Yep.
Is that what it's
Guaiac
like?
test, yep.
Guaiac test to see if they're bleeding throughout their GI tract. 'Cause that's
Stool in the blood. Give me some examples of steps to take for neutropenic precaution patients.
Don't
Patient that's
go-
in the hospital system
Oh.
or in the hospital room, what needs to be done?
Reverse isolation.
Okay, we've done that, so what else?
They can only have bottled water, everybody has to wear masks.
Mm-hmm. And the patient has to leave the room for any reason, radiology or whatever, they have to mask up. What else?
We don't give them,
fruits or vegetables.
Can they have fruits and vegetables?
Yes.
Yes.
Yes, so they need to be washed. Okay?
something.
We
with
don't allow any of the patients at St. Catherine's to have them.
They need to be washed, cooked.
Do they use plastic utensils? It was
Mm,
something that
no.
they didn't use.
Not that I'm aware of. It's not a good idea for them to have the raw food. So this is not an individual that's going to be allowed to have anything rare. An individual where the fruits and vegetables need to be washed and cooked. I don't care if they're grilled, steamed, whatever, but they have to be washed and cooked. The mask. What else?
They have to wash their hands.
Oh, okay. Is this a patient where you want to move equipment in and out of the room?
Mm-mm.
All right, so if they possibly can, they need to have their own equipment in the room. And should the visitors be bringing any gifts into the room?
No.
No, it really shouldn't be. All right, what do you want to teach patients that have gone through sickle cell crisis, they're going home, what are some things they need to avoid?
Exercise.
Yeah.
Dehydration.
Well, dehydration.
Well, everybody should avoid that, that's not a problem.
But I thought when they're dehydrated, that's when their causes.
Why no, but specifically, what
Stress.
should they? What are the big risk factor for someone in sickle cell crisis? Like,
Deoxygenation.
Clotting.
they're out of,
Infection.
they're, okay, infection. So you guys need to listen to my question a little bit here. What do you need to teach the patient? You're just gonna teach the patient to avoid infection.
Don't go into
Crowded
places like
places.
crowded places.
There you go, yeah. You can't teach a patient, don't be hypoxic. Don't go near infection. You tell them where, what to avoid.
Wash hands.
Right-sided heart failure. What can the patient monitor?
Weight.
Weight? What else?
Sodium intake.
Sodium intake? What else?
Fluid intake.
Fluid intake. What would all those manifest as? Edema!
You said fluid intake?
Yep. When it comes to the cardiac lecture, when you have the 6-second strips, when it comes to nursing school, all you need to know is your first response to that. If you have someone that's a normal size for them, what's your nursing intervention?
Nothing.
Nothing, continue monitoring. If you have someone in asystole, what's your first nursing intervention? Check the patient. Make sure your leads are hooked up. Then call it out. All right? When it comes to nursing school, I don't care if you know the difference between any of the other different blocks. Okay? This is not an ICU class. You just need to know the difference between the ones that are going to kill you and the ones where you're fine. Afibrillation going to kill you? No, probably not. Not right now. There might be stroke implications later, but in this case, you would just be continuing to monitor. If you're an uncontrolled AFib, so you're clicking away in the AFib at like 170, 180, I need to get some help. If you have anybody clicking away in the 170s, 180s, you need to get some help, okay? You understand that?
Mm-hmm.
Basically, you're just going to continue monitoring the patient, or do you need to go check on the patient? Right now, that's all you need to know for nursing school. All right, questions, comments, concerns?
That's it?
That's it.
We didn't even touch on the heart.
Yeah, I did.
Not really.
None of the infective endocardosis, anything like that.
17 minutes, I feel.